Hello, Thomas Weimbs here again, the president of Santa Barbara Nutrients. I'm at the PKD research conference in Lisbon in Portugal. It's beautiful here. The conference just finished, and I had the chance to talk to some of my colleagues here that gave talks and presentations, fantastic science at this conference. And one of the folks I was able to catch to do an interview with is Dr. Nuria Pastor-Soler. I've known Nuria for a long time. She's an associate professor of medicine in the division of nephrology and hypertension at the University of Southern California in Los Angeles, at the Keck School of Medicine there. Nuria is also the dean for research mentoring at the Keck School of Medicine down at USC. And she runs a research lab that is focusing on molecular and cellular mechanisms of metabolic pathways in chronic kidney disease. We're also happen to work together on something completely different. We're actually planning a clinical trial together on long COVID. So something completely different, subject for another video maybe one day soon. So in our interview here, I asked her and we discussed something that I actually think is really important in chronic kidney disease and in polycystic kidney disease, and that is carbohydrate addiction. So essentially food addiction caused by carbohydrates that are kind of ubiquitous, of course, in our Western foods and diets. How this can lead to metabolic disease, obesity, and so on. So actually, Nuria has a very lots of personal experiences in this regard, which really I think also helps her as a doctor, as a practicing nephrologist, to help her patients much better because she actually knows what to do about it. So here is the interview with Nuria. Okay, so we're here in Lisbon, in Portugal, at the PKD research conference. Lots of people, researchers here, scientists, nephrologists, kidney doctors, including my friend Nuria Pastor-Soler, a professor of nephrology at the University of Southern California. And we're just trying to chat a little bit about, topics of interest. And one topic is always food and eating and food addictions, maybe eating disorders, things like that. So I'm wondering, Nuria, what your take is in general. How often do you see eating disorders, food addictions in patients that you see? How big of a problem is this in general?
Oh, hi Thomas, it's great to be here in Portugal, seeing all these talks, and there's been a lot of talk about the metabolic syndrome and about how being overweight is so bad for kidney disease and for kidney disease progression. And to me, it gets personal because I take care of a lot of patients. It's known that people living with obesity have more problems in the kidney, more problems with hypertension, more problems with diabetes. And during the COVID pandemic, everybody was home, there was less activity. People became very concerned about weight gain and inactivity and being unhealthy. And for some of us, if we were already there, the COVID-19 did not help. The COVID COVID-19 pandemic. In addition, I am a practicing nephrologist. I take care of adult patients. We saw a lot of patients with COVID who were obese or overweight or almost obese, who did a lot worse with COVID-19. So that sort of was a wake-up call for me personally. And it made me look at how I eat. And it took a lot of soul searching, and I realized that I was powerless in front of food. That I would eat when I was happy, I would eat when I was sad, I would eat when I was stressed out, I would eat when I was relaxing. And I do understand a little bit of the physiology of that. When we are overweight, we have more insulin around, and having more insulin around makes you hungry all the time. So I knew my pre-diabetes numbers. I was not there, but I was heading there. So I identified as a food addict, and I took steps towards addressing this food addiction, which involved getting into support groups to help me deal with that. And one of the things that these food groups have, they have tools that you can use in front of your food addiction. And one of the tools they have is there is a group, and there is people in the group, and there is support, and there is phone calls, and there is meetings, and there is a food plan. And the more important thing for the food plan is that it's mandatory that the person who identifies as a food addict talk to their physician about, is this food plan okay for me? And the food plan is not uniform, but there are some guidelines. And one of the things that I noticed in the food plan is that the first 30 days, it was very low in carbohydrates. So as far as grains was concerned, in the first 30 days, I was only having grains in the morning, 1 serving. And then I'm a kidney doctor, and I had urine strips at home. And I checked, and I was, having some ketones in the urine. And I stopped having constant meals. I only had 3 meals a day. And between the meals, I only was allowed to drink a variety of calorie-free drinks. And I was allowed sugar-free gum as well. And then what happened is, the moment the food became organized, and the moment that I was in this ketosis, my appetite went down significantly.
Yeah, so that's actually really interesting, Nuria. So, when we talk about sort of food addiction in a Western country, the US, United States, let's say, I think what it really comes down to is probably a carbohydrate addiction, right? Because the typical diet in a Western country is like very, very high in carbohydrates. But you have sugars, refined sugars. You have natural sugars. You have starches. You have all the pastas, the pizza, the rice. And of course, all the processed foods, which tend to be very, very high in carbohydrates. And would you say that the kind of like almost the addictive effect of foods comes mostly from the carbs, from the sugar, as opposed to, that sounds like what you experienced yourself, is that as soon as you cut down on those carbs, a lot of the problems went away? Is that kind of how you experienced it?
Yes, so a very important part of this food program was, if you're only having, for the first 30 days, 1 serving of grains in the morning, and I said grains, is there was no sugar and there was no flour in my diet. So the sugar had to be number 5 in the ingredient list before I could add something to my food plan. So yes, I only then realized that half of my pantry was totally out of bounds for me because of sugar and flour. So that releasing that was very difficult. It took me 9 months, and I would occasionally cheat. And eventually I realized my weight wasn't going up, but my weight wasn't going down, because I would still eat things that didn't have sugar or flour or carbs or were whole grains. I could still overeat on that. So that's a word of caution. I could still overeat fruit. So that was another thing that was kind of controlled in that food plan, the first 30-day food plan. I could only have fruit in the morning, 1 serving.
Yeah, really excellent. To bring it back down to the level of what you actually do professionally, as a doctor, as a nephrologist, I would assume that a lot of your patients, that come to your office and visit you and have chronic kidney disease, polycystic kidney disease, that many of them probably have metabolic problems, probably a lot of overweight, obese people. And of course, the number one cause of chronic kidney disease is diabetes. So you probably see folks like this all day long. I wonder if, going through the, dietary changes yourself, does that help you advising people? Because I'm assuming you know perhaps better how to communicate things and to tell them, throw away, all your processed foods and throw them in the trash, or have you developed strategies to communicate all this?
So one important thing is that I realized the medical community, from when I was somebody who was, obese, which is not that long ago, I would realize there was a lot of judgment of my body and my habits. And the judgment made me feel even more ashamed, and it made me feel ashamed that I was out of control with the carbs and the food. And so it was a vicious circle. So right now, when I have a patient who comes in with chronic kidney disease, we know if the patient is able to lose weight, their GFR will improve. That's been shown. We know that if the patient is able to maintain their weight without gaining any further, it's going to be beneficial. What I also know is that it is dangerous for patients with chronic kidney disease to try to go on a diet or a food plan on their own. But the way things have changed for me is when I see a patient that comes in, I say to myself, he or she, this patient is one of my people. So I immediately identify with the fact that there is a struggle. At the same time, it's doable to address the carbohydrate addiction. And my language to my patients is, if you want to overcome this food addiction, because the patients eventually open up about the food addiction. I don't have to say I'm a food addict, but I talk much more non-judgmentally now than I used to. And I say to them, only you can do it, but you cannot do it alone. It's going to require a re-education of your family. And I do a lot more referrals to centers that are specialized in weight loss in preparation for either a bariatric surgery or nutritionists that are not going to tell the patients that everything they're doing is wrong. Because one thing that happened to me when I let go of the food is that I realized that what was underneath my need to eat was negative thinking. So, and that often has to do with the person having had some kind of trauma. So the mental health community is not addressing how the food epidemic and the carbohydrate eating epidemic is related to people having been extremely stressed out and dealing with some level of post-traumatic stress. So, for example, during the pandemic, a lot of people working in healthcare were gaining a lot of weight because of what we were seeing in the hospital. And a lot of people who had relatives who were sick or they couldn't go see their relatives were also using food to address those feelings and that level of thinking. So I have also approached my patients from the mental health standpoint, saying, once you let go of the food, feelings are going to come up. And so it's very important that if you are in a center that specializes in weight loss, either prior to bariatric surgery or not, that your anxiety, other endocrinological problems like thyroid disease, and trauma in the past, that all of those get addressed. And for example, so it basically addressing my need to go to food to deal with stress opened up a door towards self-care. So more meditation, more spirituality, exercising, but not to the level that I was exercising in order to keep up with the food. And also really letting go of the carbohydrates. And so right now I'm on a time where we call it maintenance, where I'm just maintaining my weight. And I do have carbohydrates in my meals. They're complex. And I'm not hungry all the time. And I'm not anxious all the time about the food, about what I'm going to eat. And I have to say that probably the ketosis that goes on when one is not consuming simple carbs helps address the hunger, the constant hunger, which it's very anxiety producing. One thing, so the medical advice for the particular person is very important. Addressing the endocrinological issues, addressing the baseline trauma or depression, anxiety is also very important. Self-care. It's been shown that the majority of people who are morbidly obese and the people who are really addicted to carbs tend to be more impulsive. Right. So somebody did a study in young adults. The young adults that were overweight were more likely to be involved in minor problems when crossing the road. So, getting into potentially being run over. And it was related to the impulsivity. So there is something there. It's like you see the carbohydrate and you're not supposed to eat it, but you eat it. So why is that? So if you're stressed out on top of it. But what happened is being on a food plan that reduced the carbohydrates, reduced my hunger. It made me get out of the desperation zone. The ketones calmed down my appetite. Then my insulin levels went down as I lost the weight. In this food plan, I lost around 50 pounds in over 2 years. But before that, I was stable. When I gave up only sugar and flour, I was stable for about 9 months. And there is a sense of satisfaction in saying I'm finally controlling something that was controlling me. So the ketogenic aspect, as well as the support groups and addressing self-care, was very important. So when I'm talking to a patient, I explore all those things in the nephrology clinic and try to make as many referrals as possible to endocrinology to nutrition, to psychological support, and to community self-help groups, 12-step groups as well, to let the patient reach out if they want, and to know that there is a way out. And I have friends that are following sort of the same path that I'm following, or I'm following them, who have let go of 189 pounds, 120 pounds, slowly but surely, with the help of their physicians, with the help of their families, with the help of the support group. And they're a lot happier now than they were.
Yeah. Well, excellent. So clearly, Nuria is I would call her an enlightened doctor who actually knows from, especially from personal experience, what actually plagues a lot of the patients, that come to the doctor's office all day long, and how to deal with it. But one question I have is, I hear this all the time from patients and from other doctors. They say, "Whoa, ketosis is dangerous. You can't do this." And believe it or not, I have a stack of nutrition textbooks under my computer at home. I use them to elevate my laptop. They all say ketosis is to be avoided. Ketosis is dangerous. And I think it comes down to sort of this confusion between ketosis and ketoacidosis. They rhyme, they sound very similar, but they really are sort of opposites. One is a physiological state and one is a pathological state. What do you think? Is it possible that a lot of even of doctors, that went through medical school and so on, get those two confused, and that this might be the reason why they're telling patients, no, you should use a low-fat diet, meaning a high-carb diet, and that the message really hasn't come across that because of this confusion?
So I think that you bring up an important point, which is the fact that as physicians, we haven't really followed up with the literature about what is good and what is bad as far as weight loss is concerned. We're all looking for the lazy pill, the pill that will reduce your appetite. Yes, there is. Ketoacidosis is very dangerous, and that's one of the reasons why I make sure that my patients and also the people who are in the same support group that I am in, they are getting labs drawn often. If people have already a predisposition to ketoacidosis, they can get quite sick. There's also a need to make sure that the patient's lipids are okay. And so what a lot of people in the community we were doing, I did it for years, is go on these food plans, these diets, and not know what's happening metabolically to the person. So I think a certain degree of ketosis is okay, provided that your provider says it's okay. If you're somebody who has insulin deficiency, it could be very dangerous. If you're somebody who has insulin resistance, then it's another story. So I think many cultures, and for many hundreds of thousands of years, we were not addicted to carbs, and we live. There is certain concerns about if you have a lot of ketones in the urine that may cause you to lose some electrolytes. Keeping up your volume status, it's important. There is a fear in the community, I agree. And at the same time, this fear is not supported by the data of people who are losing weight and are keeping the weight off. So My answer to your question is each person should be looked at individually by their physician. And then the food plan should be something that it's looked at together with the physician and supported with data. For example, I'm a kidney doctor. My GFR, my kidney function was not abnormal when I started, but it has improved since I lost the 50 pounds. My muscle mass has not decreased. I am exercising about the same. So there is a positive effect. Same thing for my blood pressure, same thing for my sleep quality. Because not being overweight, my passages are not my breathing passages are not crowded by fat, so I'm not snoring. And yes, I think more information is needed in the community to really address the obesity epidemic, and making sure that it's safe for the patient to go on a low-carb diet, and also, only for 30 days or only for a few weeks until... So I eat a lot of carbs. They're just the right kind of carbs. They're complex carbs. I eat a lot of squash. I eat a lot of beets. I have sweet potatoes, but I don't have any flour, I don't have any sugar, and I don't have any white rice, which in 5 minutes is sugar. So my advice to patients is get yourself looked at in depth, have a conversation with your doctor. If your doctor doesn't know, have a conversation with the nutritionist and say, is it safe for me to go on this food plan, which is going to induce a little bit of ketosis, lower my appetite while I lose the fat, and then once the fat is gone, I won't have insulin resistance and I won't be hungry all the time. So I don't think one size fits all, but I think there is one path, and everybody needs to take it at their own pace with help.
Wonderful. Thank you so much, Nuria. I think that was really enlightening. And hopefully, folks out there have learned, a thing or two. And, I think almost, maybe like more than 50% of the people in the US, certainly much more of the people that show up at doctors' offices struggle with exactly this, with excessive carbohydrate intake, overweight, obesity, which is never a good thing. Hopefully you all have a doctor that knows what to do in cases like this, and knows what kind of advice to give them. If you don't, maybe ask another doctor, shop around, you have your choice of doctors these days. Good. Yeah. So maybe last word goes to Nuria. Anything else you want to say?
Well, I want to say that it's not easy to identify as a food addict. There's a lot of shame around it. And that's one thing that I would like to take down. There should be no shame. And doctors, we should not make people feel ashamed of their weight or their diet. People are doing the best they can. And I don't impose that on my patients. But if they ask me, I will contest. Say, this is what I did, this is what can be done. There are all these programs, there are all these places you can go to. I think the more we talk about food addiction, carbohydrate addiction, the more we debunk it, there'll be less suffering out there, because I suffered for many years.
Great. Thank you very much, Nuria. Really appreciate it. Looking forward to the rest of the conference here. All right. Thanks you.